Good morning, and a very warm welcome on behalf of EFPIA to this online debate on what delays access to medicines. My name is Jackie Davis. I have the privilege of moderating our discussions this morning, and we're going to have a totally interactive debate after a presentation to provide some context for our discussion and a fireside chat with an MEP who's worked intensively on these issues. Some housekeeping before we start. During the panel, as I said, it will be totally interactive. We'll start with some questions from me, and then I hope also from all of you. You are all muted for now. If you want to ask a question, there are two ways you can do it. You either click on the Q&A button, write your question in, and please, could I ask if you could be brief so that I can see very quickly what your question is and who it's for? Could I suggest perhaps Twitter length or less? Please use the Q&A button, not the chat button. If you have a technical issue, a problem hearing or seeing the webinar, then you can click on there, write a message to the organisers, and they will try to help you. But for questions to our panel, please, the Q&A box. If you want to ask your question orally, click on the raise hand buttons, and when the time comes, I will unmute you, tell you I've done so, and give you the floor. No need to put your camera on if you're asking a question, so if you're watching us in your pajamas still, that's absolutely fine. No one's going to know. The Twitter hashtag, if you would like to share what you are hearing in this discussion with the outside world, and we do encourage you to do so, there are two hashtags you can use. The EFPIA hashtag for its autumn webinar series of conversations, Questions Inspire Solutions, or the hashtag We Won't Rest. So that's it for housekeeping. Let us get underway. And as I mentioned earlier, we're going to start with a context-setting presentation, and I'm delighted to welcome Tim Wilsden, who is Vice President of the consultancy Charles River Associates, CRA, who's going to reveal to us the findings of the 2019 Patient Weight Indicator Survey, and then that will provide some context, as I say, for the discussion, and then I'll have a chat with our MEP. I'll introduce the other speakers to you as we go along. But for now, Tim, over to you to get us underway.
Thank you very much, Jackie, and thank you to have the opportunity to talk about this piece of research with you today. So I've got 10 minutes, so I'm going to cut to the chase relatively quickly to talk you through EFPIA's recent publication on the root causes of unavailability and delay, and I'll come quickly to defining both of those terms. So just to give you a little bit of background and context for the work, clearly the starting point of this is the terrific amount of innovation and the benefits this brings to patients. There's common agreement across all stakeholders that innovation and innovative medicines are only of value if they actually are accessible and patients have access to these treatments. And it's been recognized for a long period of time, partly because of the weight study that's been done by EFPIA over many years. So we have different levels of availability across the European Union, with long delays in some markets before patients have access to some very important innovative treatments. So the question we tried to address this year was to go behind the weight data. I'll show some of that in a second, but I'm sure many people are very aware of it, and look at the root causes. What's causing unavailability? What's causing these delays? Building on the work by many other authors, including the European Commission, academia, but particularly looking at the work that's been commissioned by EFPIA in 2020. So some deep dives into the weight analysis by IQVIA, the EFPIA oncology platform, working with Ventura, looking at time to patient access, and surveys of the legal framework in different countries. What do we mean by availability and delay? Well, we're looking really at quite a wide definition of delay in this piece of work. So we're looking all the time from the application for marketing authorization, largely thinking about the centralized process here. So the time of application to EMA, the granting of marketing authorization, and then the length of time for application to pricing and reimbursement, the length of time of the pricing reimbursement process itself, including the component of value assessment. So we're trying to take quite a holistic perspective on the length of time before patients have access to medicines. What's the evidence? Well, as before, EFPIA has published the 2019 WAIT Survey, which gives a survey of a 4-year cohort of products going through EMA, and then looks at when they get through national reimbursement. And what we can see from that is wide variation in the time to availability. The quickest markets down at 120 days on average, some of the slowest markets up at 820 days. So significant variation in delay, significant variation in the percentage of those products that are available at the time of the survey, the map on the right-hand side. We've also got quite a lot of granularity, looking at different therapy areas. So oncology medicines versus rare diseases. We've seen oncology improve, but unfortunately we haven't seen orphan medicines get any quicker. We then see very large variation even within a country. So looking at some of the widest variations, the fastest product got through in 20 days, where it took over 1,400 days for the slowest product. But probably of most concern coming out of this survey is we start to compare the results from year to year. We actually see we're not actually getting any faster. So a real concern, particularly when you bring in the issue of COVID and whether that will have any implications for the speed of availability. So it's very good time to be thinking about what are the root causes and what can we do about it. So turning to our analysis, this is a widely discussed issue, of course, and there's many papers that have looked at this from different perspectives. And in reviewing this and doing the literature research, we find many cases of the papers looking at the industry behavior or commercial behavior, strategic decision-making, and the role of launch sequencing. Alternatively, if you read alternative perspectives, you find the slowness of the pricing reimbursement process, the decision-making process, looking at that's the underlying factor driving delay. What we find, and I suppose a headline of the study, is, well, it's both. By its nature, the root causes of delay are interrelated, and it's very difficult to unpick one from the other. When you find differences in the environment, that's leading to differences in commercial decision making. So the headline of the study is this is multifactorial, and it's an interrelationship between the environment and commercial decision making. We can go a little bit further than that. We can put the causes of delay into 5 categories. So time to marketing authorization, pricing and reimbursement, the value assessment, health system readiness, and delays between national and regional, which is often overlooked. And within those 5 categories, we end up with 10 root causes. I'm very briefly going to pick out some highlights in the next couple of minutes. So the first one is the speed of the regulatory process. Sometimes this is overlooked, but I think as set out in the recent OECD report as well, the differences between Europe and the US are startling. They don't seem to be getting smaller. So it just, on average at least, it's taking longer from application to marketing authorization in Europe than it is in the US. And that's the start of the delay, I suppose, for patient access to medicines. If we then look at the pricing and reimbursement process, there are different components of that, and hopefully that's one of the benefits of this piece of work. There's the initiation process. In some markets, you can start this immediately. In other markets, there's a period of time before the price and reimbursement process is even initiated. Then there's the length of the pricing and reimbursement process itself. If you look at the drivers of those two, well, clearly in terms of initiation, there are a number of different factors. One is external reference pricing, which has been very well documented. Another is resources, and we find smaller companies launch less quickly across markets than larger companies. In some cases, it's not actually the choice of the company. There are regulatory rules in the pricing and reimbursement initiation about the number of countries already on the market, or even the role of other stakeholders. So there's a number of different factors affecting initiation. When we get into the pricing and reimbursement process, that clearly varies across countries quite significantly and compared to the stated timelines. What are the reasons for that? And here we're drawing on the time to patient access study. Well, one of the things is delays and stop clocks within the value assessment process. There clearly are different interpretations of what evidence is required to show value, the need for national evidence versus global data. Actually establishing additional data takes time. And as was shown in the TPA study, across 19 factors, there's significant variations if we compare the big regulatory agencies even to EMA. Some areas, a lot of common agreement, others, significant degrees of acceptability of different types of evidence. So misalignment on evidence requirements is still a problem, and a significant one in Europe. Misalignment of value and price. We've got very significant differences in the income across the EU. The degree to which prices align with income clearly varies quite significantly. And one of the where we get misalignment of price and the national value assessment is, again, it's going to lead to delays. I suppose one of the interesting observations here is we see that the use of different mechanisms which allow price to align with value, novel pricing models or managed entry agreements, we find the lack of use of those is also aligned where we're seeing the biggest delays. Central and Eastern Europe, where we've got some of the longest delays, are not using these types of agreement as often as some of the other markets. And that, we think, is part of the root cause of this issue. Health system readiness. Again, we've got very large differences in income, 16,000 to 80,000. In any other issue where we've got very large differences across countries, we would expect different prioritization across some of those markets. So where we've got very different levels of budgets, healthcare affordability is clearly an issue, and we would expect different priorities across markets, which we see. But we also see the investments in the healthcare infrastructure, particularly diagnostics, but also the development of centers of excellence for orphan medicines, means that the difficulty in finding patients in some of these markets means the commercial viability of serving those is clearly varies quite significantly from market to market. And again, may not then be a surprise that markets are prioritized at a different time. So health system readiness and the alignment to income, but also the resources that are invested in the healthcare infrastructure is clearly important. So we've got 5 different categories driving availability and delay. I think one thing we didn't want to leave out of this report is, even though we've taken a wide definition of availability and delay, that's not actually access. Access is patients actually getting the product, the medicine, actually delivering on their healthcare needs. And one interesting piece of analysis that IQVIA did, going further than the weight analysis, is to say, where are products got availability, they're through national reimbursement, but are they actually being used? And clearly some difficulties in different countries in the reporting. What we find is about 15% of products are available, but patients don't have access. And this is clearly quite important when we start to think about solutions. So my last slide. So what do we actually think of the solution? You'll find the solutions part of this paper are shorter than the diagnosis. This is clearly the debate we'd like to have. Given we find the root causes of delay multifactorial, I don't think it should surprise you that we find the solutions are likely to be multiple as well, and follow the 5 different categories of root causes. So we think the opportunity to have a dialogue about solutions are in 5 areas. One, about speeding up the regulatory process in Europe, trying to gain some of those months that we can see in other regions of the world. Number 2, hopefully transparency in the weight data itself shows the benefits in this, in terms of understanding differences, understanding the root causes. We think this could go further in terms of diagnosing the length of time it takes to get medicines onto the market, how this varies by different therapy areas. And this is an area where greater transparency would really help. The alignment of prices to value and ability to pay. This is clearly a significant area, an area of concern. One of the solutions of this could be around differential pricing, but clearly novel payment models, in our view, are a mechanism for flexibility and help in this area. Further work should be done. And then efficiency and the value assessment process. There's still significant difference. We know this has been a long debate, but this is still an area where further work and what we actually do to bring alignment across the EU is important. And then finally, what do we do about ensuring equity across markets? That's the underlying concern here, and especially across member states. We've got some biggest issues around the CEE markets. So are there issues around groups of countries or mechanisms of commitment that we could think in terms of improving access? I'll stop there, Jackie, and turn it back to you.
Thank you very much indeed, Tim. So lots to discuss there, and we'll come back to those suggestions, proposals for solutions. As Tim says, the key here is to discuss and work together on finding solutions to these complex problems. We're going to have a panel later on to discuss this, but first, I am delighted to welcome Dolores Montserrat, MEP, who's a member of the European Parliament's Environment, Public Health and Food Safety Committee. She's a member of the Special Committee on Beating Cancer, and she's also chair of the Parliament's Petitions Committee. Dolores couldn't stay with us for the whole session, so I'm going to have a chat with her, a fireside chat if you like. We have no fire, but imagine a fireside, and then I will introduce the rest of the panel to discuss the same issues that I'm going to talk to Dolores about. Now, it's a very warm welcome, and thank you very much to you for finding time to join us. Dolores, your first reaction when you hear Tim's analysis, as I say, going behind that data to reveal these wide variations in the time to availability, and some of the many factors, he says, lie behind it. Does that concord with your view of what's causing the problem and why these delays and why such big differences between one member state and another and so on? What for you are the root causes?
Good morning, everybody. Thank you very much, Jackie. And I would like to thank FPI for inviting me to this event. I congratulate FPI for the report, which highlights the causes of this problem affecting all the countries of the European Union to varying degrees. I'm totally agree on the results of your report. The main problem for me, like, you know, I've been Minister of Health in Spain. Spain is a big country that has 47 million of citizens. So the main problem are linked to the slow procedures and the excessive bureaucracy that many times double the work performs the EMA. Because sometimes, you know, this work is doing by EMA, and I think that we have to coordinate the national health systems and in the same time the national agencies, because every country has a national agency. But in the same time, we have to think that, you know, we have a different type of countries. I mean, Malta, for example, it's a small country that sometimes some of the countries, they are doing a very good job and work, but they have new agencies, for example. So for me, the first thing very important is to coordinate the national agencies with EMA. The second thing for us, for EPP, it's very important that the European Medicines Agency, in this term, we decide to give to EMA more health competence and strengthen, and we think that the EMA has to be strengthened and more efficient with the attribution of more health and competence to the Union. The urgency of the search for a vaccine has shown that more efficient ways of carrying out the drugs approval process is possible without renouncing safety and improving transparency. For example, by moving forward with evaluations hand in hand with research and clinical trials without waiting to have all the data and results at the end. The commitment of all member states is needed to make barriers disappear and improve procedures. But let me just think the last thing in this first question. Of course that we need transparency, balance in the praise, efficiency and equality and solidarity across Europe. But when I was a minister, we tried to do centralized purchasing when Malta was doing the semester, and we tried to do it between all the countries in the south, Portugal, Spain, Italy, Malta, Cyprus, Ireland. They decided to join us because we wanted to reduce the bureaucracy and we wanted to give, you know, the same price for the access of the innovative medicines. But, you know, sometimes we find obstacles, a lot of obstacles, because we don't have transparency. And I'm going to put an example. When I was a minister, we bought the medicines, the innovative medicines to fight against the hepatitis. And we pay a big price, but I know that in other countries they pay 50% less than us. And that countries, they were little countries, and it was not Spain. So I mean that the most important thing is the transparency. And I think that we have to give more competence to EMA. We have to coordinate better the national agencies. And of course that for the innovative medicines, we have to try to do a centralized purchasing, or try to work all together, all the stakeholders, the industry and the governments and the EMA, of course, and the Commission.
Yeah, and on that point about working together, and this indeed, Tim was saying earlier, because of these interrelated factors, because there are so many causes and such a complex issue to address, that we need this multifaceted approach. Do you support the idea of a high-level forum on better access to health innovations? Or do you think we need a new platform to make sure that collaboration happens?
Yes, of course, always in all the webinars and meetings that I participate, always I'm saying that I'm convinced that there is a need for a high-level European permanent forum with all the stakeholders to allow for intensive discussions and opportunities to work together, patients, health professionals, for pharmaceutical industry, researchers, and politicians, for a true Europe of health, joining forces, renewing tools, and improving solutions. Because if we're doing all together, I'm sure that we are going to have the solution that is more transparency, balance on the price, efficiency and quality, and solidarity across Europe. I'm going to put two examples that I think that we can put this pilot high-level European permanent forum. For example, in the new European pharmaceutical strategy, I think that we have to facilitate dialogue and the creation of synergies from the strategy for, to all the stakeholders. And in the same time, that Europe now, the Commission and the Parliament, we are working with the European Beating Cancer Plan that we are going to have it at the end of the beginning of the plan. We are going to have it at the end of December. So I think that it's these two, the European Beating Cancer Plan and the new European Pharmaceutical Strategy, are two plans, two strategies that we have the most important opportunity. We have a really big opportunity to make this high-level European permanent forum with all patients, stakeholders, industry, politicians, researchers, everybody. For me, it's very important. Always I'm proposing.
And the last question, Dolores, you refer there to the pharmaceutical strategy. We also, of course, have the review of the orphan and pediatric medicines regulations. Apart from creating that forum for dialogue, for evidence-based dialogue, is there anything else you want to see, particularly in the pharmaceutical strategy, in order to advance on addressing some of these issues? And you talked about more competence for the EMA. You want to see a change in the EU's competencies in this area, or merely to beef up the agency's powers specifically?
Well, I'm starting from the end of your question. I explained before, we will have the Commission and the Parliament and the EPP. I'm a member of the EPP, and we are the majority, the biggest party in the Parliament. We, like EPP, we won, and I'm sure that we will have a European Medicine Agency strengthened and more efficient, with the attribution of more health competence to the Union. We have to give to EMA more competence, and we saw it with the vaccine. The urgency of the search for a vaccine has shown that more efficient ways of carrying out the drugs approval process is possible, without, of course, renouncing safety and improving transparency. The second question, the new European pharmaceutical strategy, which the Commission will present at 24th of November, aims to improve and accelerate patient access to safe and affordable medicines and support innovation in the European Union pharmaceutical industry to remain a world leader. For us, it's very important to maintain to remain a world leader. We in the Parliament will work to ensure that the Commission proposal integrate a holistic, patient-centered approach with a long-term systemic view covering the entire life cycle of pharmaceutical products, and to guarantee the rights of Europeans to the best treatment in any country of the Union they live. Promoting this, of course, that we have to promote the sustainability of the market and public finance, and we will facilitate dialogue and the creation of synergies from the strategy, not only with the other mentioned initiatives, but also with the other European Union key policies and priorities, like the Green Deal, the Horizon Europe, the industrial and the competition strategy, as well as intellectual property rights. And we will be vigilant so that it can also represent an important first step towards a new regulatory framework for medicines for unmet medical needs. So I clearly invite all companies and patients organizations to continue to be involved in the discussion and to contribute from their perspectives.
Thank you. So very much a holistic approach, tackling all these factors together in order to come up with solutions to what, as we've already established, is a very complex problem. Thank you so much, Dolores, for that. And thank you for your passion on this topic. We know you have a very busy day and you have to leave us, but we are very grateful that you were able to join us. You've given us lots to discuss with our panel. So I'm very grateful to you. Thank you so much and have a very good day.
Thank you very much.
Thank you. So, as Dolores leaves us, joining me now to discuss this, I'm delighted to welcome Francis Arix, who is head of the Directorate for Pharmaceutical Policy at INAMI in Belgium, Gabriele Grom, Associate Vice President, Central Eastern Europe at the pharmaceutical company MSD and Chair of the EFPIA CEE Task Force, and Kaisa Imonen, Director of Policy at the European Patients Forum. So a very warm welcome to all of you. It's good to have you with us. And I wanted to start really, and Tim is back. Thank you, Tim. Great to see you again. There are some questions already coming in, but I'm going to ask some questions to our panel first, and then I will bring all of you in. As I say, you can write them or you can put your hand up, mainly written questions coming in so far. But Francis, you've been listening to Tim and you listened to Dolores and their analysis of the root causes of these delays. Would you agree with what you've heard? Is there anything you would add to this? Is there an element that we are perhaps overlooking or not emphasizing enough?
Well, thank you for the opportunity. First of all, thank you for the opportunity to join your conversation. And I'm really happy that that many people are actually trying to follow. I saw already the first question, so that looks interesting. There's a few things, yes. It came to me that, I look at it that availability or accessibility apparently is defined as fully reimbursed. A drug is only accessible if it's fully reimbursed. I don't tend to agree to that. We already give access to new therapies and innovative therapies through clinical trials, for instance, and to compassionate use programs, medical need programs, lots of early access programs that actually exist everywhere, and our patients have access to that through that. So maybe we should not be so narrow looking and just looking at the only solution for quicker access is fully reimbursement of the drug. We might invent, and actually in Belgium we're working on that, in alternative versions where we give earlier access or faster access to drugs, partially reimbursed or already with some sort of financial support from society, but not fully reimbursed. That's not really honest, I think. Two, you have a completely different, there is no such thing like, I don't agree that there is in Europe. There is no such thing like Europe. Look at GDP, which means purchasing power, obviously. That means that there's so much diversity in Europe that one access and one speed and one way of doing everything, doing this for everyone is not going to work. Look at the organization of health, for instance. In Belgium, if you look at a system like the Belgium system, a drug gets reimbursed if it's fully reimbursed for everything. In a few other countries, you have lump sum reimbursement through hospitals, where actually you can get immediate access and immediate availability for patients for your drugs, because it doesn't have to go through the whole federal or national process. And then you get very strange figures, and you can't compare really the figures on access or availability between the different countries, even in countries with the same sort of purchasing power and the same level of ability to pay for something.
Can I just, sorry,
Yeah.
did you want to add something? I wanted to just ask, following up on that, but does that to you mean that we can't learn lessons from those, for example, I think in Germany, the average wait is something like 127 days. That's at the bottom of the range. In Poland, over 800 days. Are you saying there that one country can't learn lessons from another, or simply that we can't cut and paste the solution, as it were? Or
you can learn lessons. Obviously, you can learn lessons one from it. You have to learn lessons one from another, and that's one I've seen a question. That's one of the questions also. That's one of the reasons why the Benelux exists. Why we try to, why the Nordic collaboration exists. Another, it's to learn from each other. You have to learn lessons for each other, but. Just comparing figures and delays to a full reimbursement decision, that's a bit, well...
Too simplistic.
Yeah.
Yeah, so you're referring there to a question from Mark Dooms, who said, will European initiatives such as Benelux A speed up access? I think you're saying, yes, they can.
No, yes, they are. Yeah, but I look at the five, and I agree with Tim. The five big solutions, it's not the five solutions, it's the five domains where you have to work in. One of the domains was better health, not better health, better quality of your assessments, of your value assessments.
Yeah.
That's why we're doing joint HTA. If you put the brains of, or the expertise or the capacity, the personal capacity of 5 countries together, you have a peer review system between peers coming from different angles, and you have better quality. So it's already doing that.
Thank you.
Yes,
just that on the table, and then we'll come back to it a bit later on. But Gabriele, if I could turn to you, and from an industry perspective, you heard Tim's presentation and what he sees as the key explanations behind the numbers. Francis there saying, yeah, the numbers themselves. It's too simplistic to look at those and draw conclusions just from that. But he also identified, I think, focusing a lot on the reimbursement issue and a lot on what your definition of access is. For you, what would you agree with what you've heard? What would you highlight as the key challenges we need to address?
So thank you very much, Jackie, for the introduction, and I'm very, very happy to be able today to discuss with you on this very important topic. So I have been working in Central Eastern Europe for several years. And Central Eastern Europe, this is what we have seen on Tim's report. These are the countries with the major delays. And so here access for patients is usually delayed. There is this very, very impressive example between Germany with 127 days and Poland 823 days. I agree, this is just numbers, what we see there, and maybe we need to look a little bit deeper into all the reasons. On the other hand, I still feel that patients in these countries, which are maybe from an economic situation, are not 100% comparable to the Western European countries. Still, I think if you think about the value of innovation, it's only realized when patients can really benefit from the advances in treatment. And I'm somehow concerned about the situation of unequal access, which harms patients, which I can watch every day. Personally, I live in Vienna, Austria. So me and my family are really benefiting from a very, very, I would say, well-developed healthcare system. If I turn to 50 kilometers, I'm in Slovakia. And if I would be a patient there, or my family would be a patient there, I would have completely different opportunities. And I think that there is many factors which are causing these differences. And I think it's not an easy one to just say, we have to resolve it and there is one solution. We need, first of all, to understand what are the drivers behind that. and are these drivers which we can address to, and what are the proposals to work together to basically improve the situation. I agree that reimbursement is not the only access in the markets, because there are different mechanisms, and there are very good examples in some markets where patients might benefit from early access within the kind of the framework and the system. But of course, if you think about an innovation, you want to be sure that at least most of the patients which urgently need your innovation and can benefit from it, that they have access to it. And with just having it available for clinical trial, this will again exclude many, many patients. So what I see every day in these markets is, and sometimes I'm a bit frustrated on some of the bureaucracy which I see there. I see that some of the local reimbursement processes within the countries are not very efficient. There is a lot of need to create additional local evidence. So that means that even if EMA kind of evaluated the process already, there is some duplication on efforts. There is a lot of need for generating local data, which would need to be submitted for wider access for reimbursement. And also what I see is that sometimes countries rely on reimbursement and access in one country, or even up to five countries, before it can go into the reimbursement in one local environment. For example, Bulgaria, the product needs to have 5 approvals, reimbursement approvals across EU before it can go into reimbursement in Bulgaria. Of course, these are very simple reasons to explain some of the delays, but that's not all. I mean, there are even tons more, which I see every day.
Indeed, and that point about bureaucracy, which Dolores made as her very first point, it's slow, there is excessive bureaucracy, this duplication of evidence, the need for local data. And I want to come back on that because I want to link that to Francis's point about we can't do it the same everywhere, but is there a degree, and can we maybe learn something from the Bulgaria experience where they say 5 other countries have had to do it before we'll do it? So does that lead us to a more coordinated approach? But let's complete the picture. Kaiser, I know that the European Patient Forum has done its own work in this area on the issue of delays to access. What have you discovered, and does it chime with what we're hearing so far from our other speakers?
Thank you, Jackie, and good morning, everyone. I'm just going to speak a little bit briefly about how what we see as some of the barriers to access, but I want to start to say that we define access in a different way. So we do not use the same definition as the EFPIA survey, and we do not only focus on time. So obviously time is important, but that's not the only factor. We use what we call the 5 A's framework, namely availability, which means availability in the market, affordability, which is absolutely key, which means that patients should not suffer financial hardship as a result of seeking treatment, and neither should the healthcare system, which in Europe usually is meant to provide treatment for patients who need it, suffer financial hardship as a result of seeking to provide treatment for all their citizens. And then adequacy, which relates to the safety, quality, and efficacy of medicines, appropriateness, which means meeting patient needs, and accessibility, which refers more to reachable channels and sort of physical barriers, for example. So clearly this report has a specific scope, and it means that it has benefits, but it also has limits. And we see, obviously, there are a number of reasons for a lack of access to medicines, and they're not likely the same in every country. So we need to also know the patient perspective on what those reasons are. I can't provide you an overview answer today, but we're obviously working on that with our membership. You see, obviously, that it's not surprising that the gradient seen in this survey is broadly similar to other studies that we've seen on access to healthcare broadly. So the countries with fewer resources tend to be towards the lower end, and vice versa. We do see some specific factors affecting access. First, there's that tension between the centralized approval in the EU and then the steps that follow, which are in the domain of the member states. So certainly from our perspective, the lack of European HTA, for example, is a contributing factor, or to put it the other way around, to have a European HTA framework would, in our view, likely lead to more equitable access to valuable innovation. Then there's that evidence gap, which was presented as the misalignment of evidence requirement. Yes, I think we see that as a barrier that needs to be tackled. And in our view, that means bringing the evidence requirement for HTA and pricing and reimbursement decisions more upstream, so the data, as far as possible, could already be incorporated before it comes to that stage. And we fully recognize the complexities of doing that. Affordability is a major barrier, and this is not only in low resource countries anymore, as we all know from the discussions that have taken place in the last years. Last week at Gastein, the Norwegian health minister said they were only able to take on half of the new drugs because of affordability issues. And this is one of the most richest countries in the world. So that is a significant issue. And this is linked, in our view, also to the lack of transparency in the system. But I think we'll probably return to this point of transparency later on. This is also something that we in EPF feel quite strongly about.
Thank you very much indeed. So lots to discuss. There are lots of questions coming in. I'll come to those in a little while. But I wanted to also pick up, Tim, on something you indicated, where you said it's not getting any faster. We're not improving. And you said there is a concern that COVID-19 will make this situation worse. Why do you think this is proving such a difficult, to use a very English expression, nut to crack? Why are we not seeing any improvements?
I think, as Frank was suggested, that you do have to look at this on a country by country basis, and it varies a lot. So we are seeing improvement in some countries, we're seeing a worsening situation in others. So Jackie, I think the first point is the analysis. You need the data, you need to be able to look at it, and often there are trends going in different directions, and there are some positive things. I think the early access mechanisms we talked about before have significantly improved speed, and I accept the point on we should be interested in access, and availability is only part of that by our definition. So there are some positive things going on in the oncology space that we've all been focusing on very much in the last 5 years. You have seen some improvements in the weight data. Unfortunately, in the rare space, which we're seeing more and more of the medicines coming through, and you actually see the situation very much stay the same, arguably in some markets get considerably worse. So I think the first thing is important to understand the data and understand what's going on underneath, because it's not a simple trend across all markets, I think, as we probably agree. I do think, and we're hoping this report helps in this area, we do think there's been a kind of a blame game of saying, well, it's your fault or your fault, and really it's a combination. It's everyone's fault, and the patient is losing out because of this, and we need to get together and sort this out. So I think one of the things that we don't have all the answers in this paper, and certainly from CRA's perspective, we don't know all the answers. We just know that this is an area where we have the same ambition. Everyone has the same ambition, but we seem to be a little bit loggerheads in terms of what to do about it.
Kaiser, can I come back to you on this transparency question, because you said it's a very important issue for you, and it's one of the factors, one of the issues identified in the report that Tim was presented, where we need to do work. What would you like to see in this area? And comment from you all on that, and then maybe we'll take some questions from the room.
Sure. I mean, I think it's positive that the report mentions transparency, although I didn't see really any concrete proposals for action from what the industry feels that could be done concretely or how they could contribute. From our point of view, transparency is actually a whole system issue. So we want to be able to better understand, for example, how the cost of a medicine relates to the cost of its research and development investment, the role of public investment and what that plays, what role that plays in the final product's pricing, for example. Transparency of clinical trials and reporting of research data, that's super important, and it's becoming a real issue again with the COVID-19 vaccines and therapeutics being developed today. I think here there should be an alignment between EU and WHO actions. But there's also another aspect, which is the transparency to patients and more widely perhaps citizens as users of the healthcare system. So we are also asking national authorities and governments to be more transparent about, for example, what criteria and what processes they use on HTA and evaluations of medicines and their decisions on reimbursement, and also how patients can contribute, because the system is still very opaque to patient organizations who want to get involved. So we call on a commitment and concrete actions from both the industry side and the government side to become more transparent.
Thank you very much. Gabriela, a thought from you perhaps on the role of the patients within this, and more broadly, Kajsa saying there, you know, how does the industry see this issue of transparency? Is it one of the factors that you would highlight as most central? What for you, we've talked about so many different interrelated factors. What for you are the key ones we need to address first?
So I think also from my point of view, I think we need more transparency, but also I think we need much more collaboration. And I really like what you just said on the joint HTA assessment. That's also something which I see that here we could really align between different stakeholders. We could learn from each other, and we could actually make evaluation processes for better quality and also much faster speed. We would save a lot of resources on many different platforms, capacities which we are currently wasting, I would say, in different things, and where we also are seeing to a certain extent in the processes not enough transparency. And I think what we want to increase is, of course, transparency of all the information regarding placing on the market some of the centrally approved products. It's clear and it's not visible, especially for the patients on where things stand, what they would like to have, for example, or what they could have, giving all the fast speed in all the developments around them. So it's very difficult to get the light into many different angles where decisions are made and where decisions are not necessarily clearly kind of on how they were taken.
Thank you. Francis, you talked about what the Benelux are doing together, but this call for a European HTA framework, would you support that? And if you would, how do you think it would work?
Yeah, that's a complicated, yes, we would support that, but how it would work would be a very complicated one. I suppose it will work like any European system or organization work, and that means a lot of coordination and a lot of, and I am a little bit afraid on a lot of compromises on the end result. And I'm a bit scared of the speed. So that's actually why we're doing, well, it depends a bit on how you're working. You are working with, we're working now within the regulations of the Transparency Directive, 89/105, twice 90 days, and you have to go quick with your HTA, and you have to go quick with your decision. That's why we're doing the Benelux joint HTAs, because you're confronted with a claim and you have to deliver a decision within 180 days or twice 90 days. If there's no, we are using already the UNETA or the joint HTAs that are available, but they're not that many that are available. And I think it depends on how joint HTA would work. If it would work with the horizon scan, look 2 years, 3 years, 4 years, and upfront on what is coming, and then start collecting with the company, start collecting the evidence that is available, and you can do a lot of work upfront, then we would have timely joint HTAs or timely European HTAs that everybody could use. So I hope it works in that direction.
So anticipation would be key.
Sorry?
Anticipation would be key. Otherwise,
it's going to be key. That's the reason why there was this problem with the uptake of the UNETA reports. Why don't these reports are of high quality? That's undoubted. But why is there no uptake? Because they're too late. Because you have an HTA, you have a UNETA HTA report a year or 2 years after marketing authorization. You have to decide on pricing and on reimbursement, where you need the value assessment 6 months after marketing authorization or something like that. It's too late.
Tim, do you think a European framework, HTA framework, would help to tackle some of those issues that you've talked about? Or do you share Francis's concern is, yes, potentially, but it could also slow things down if we don't get it right? Sorry, Francis.
Well, it's not going to slow down if it's well done, and it's going to, the quality no doubt, no doubt at all.
Yeah. If we do it well.
Just the speed.
Yeah.
But I do think, and hopefully Francis will agree with me, I think one of the big improvements that UNETA have done as we've moved from Joint Action 2 to Joint Action 3 is speeding up the process. So I think the early problems we had of the very, very late assessments has largely been solved, and credit to them and credit to the industry for sticking to those timelines. So I think the current assessments are coming out, and they're coming out after the marketing authorization, but that's kind of inevitable. There are some countries where obviously the HTA process happens before marketing authorization. That's just a very difficult challenge to do. So I think, can we get it as fast as the fastest country in Europe? Maybe not. Can we get it so it's very fast? Yes. So I think the recent, I suppose, the last couple of years of assessments have been done to a very strict timetable. So that, I would say, that's less of an issue. It's the use of them, and encouraging countries to use them effectively is the real issue. And so I think that's where I suppose we've got the questions going forward. I do think it's quite important, and we talk about value assessment here, but I suppose we're talking about the clinical assessment. I do think that's the part we should be focusing on. If we can get that part to work well, clearly as it goes into the affordability assessment and the cost effectiveness assessment, different countries are doing it in very, very different ways. And I don't see really the opportunity in that area in the same way. So I do think if this remains focused on the clinical assessment, and we keep the gains that we've had moving from Joint Action 2 to Joint Action 3, so we've got to make sure we keep those benefits. It should be being used, and it's great that it is in Belgium and Benelux, or it should be being used in other countries as well.
Gabriella and Kaiser, your reaction on this, and then I'll come to the audience. But there is one question, I think it refers to what we're talking about here, but it's a very short question. Are we not building too many layers? So is there a risk on that side? But thoughts from Gabriella and Kaiser, and then we'll take some more questions from the audience. Gabriella.
Yeah, so many layers. I think, yes, we have a very, very high complexity in all the healthcare decisions, and we have many, many different stakeholders which are impacting these decisions. There is a big, so on one hand, we have, of course, the union, we have the EMA, we have all these regulatory affairs approvals, but then we have within the countries, we have we have in each country within the EU, we have a completely different kind of system on how decisions are made when it comes to creating access or availability of products for the patients. And so this is, of course, something which is very, very difficult to overcome and to create, to first of all understand what are the issues in each of the individual countries on where we see that there is some bottleneck, where there is some kind of slowness. We see that on the other hand, we also see a lot of very positive examples. And I think Belgium has a couple of really good examples where through flexible, I would say, agreements, there has been solutions which create much better access for patients. Unfortunately, what I see in Central Eastern Europe, in many countries, even the framework which is currently in place for evaluation and potential access to the markets, some of these frameworks are not flexible at all, that they would allow for individual agreements where the needs for the country and for the patients could be kind of tailor-made, or solutions can be tailor-made according to exactly the need in the country. And that, of course, is something which is very dissatisfying. There are also countries where there are some HTA thresholds established, which none of any innovative products would ever kind of meet. And with this, there is just a way out of the market. There is just a way that you can make the product available, but patients would need to kind of fund it themselves, which is not acceptable. And I think we need the space to also be able to shape individual solutions with the healthcare authorities or decision makers.
Thank you. Guys, a quick thought, if you would. Tim, I think you signaled you might want to come in here briefly, if you would, because lots of questions coming in now. Kaiser.
Yeah, thanks. Just very quickly, I mean, obviously complexity is a fact and we can't get away from it. Our health systems are historically differently structured, and even in HTA, the agencies work with different methods and different, for example, including different types of costs and so on. We do see there's promise in, especially in European level horizon scanning, and the kind of effective HTA. Yes, I think it can be done. It requires obviously a lot of consideration to methods, but there's also promise in joint procurement, obviously, and joint pricing negotiations, particularly for certain types of medicines. I just want to be clear on HTA that we see it as a necessary part of post-approval evaluation, and we do not think that a speedy HTA is a value in itself. It also has to be a robust and high-quality HTA. What needs to be improved at both European and national levels is the mechanisms for patient involvement in that process. But absolutely, it is necessary and it needs to be done at the highest level of quality.
Okay. Lots of questions about what this European HTA, how it might work and so on. We'll come back. But Tim, I think you wanted to come in briefly here.
I was just going to make a very simple point that we've often been good at thinking about how to consolidate and centralize and add a layer. We've been less good at taking away layers from other parts of the system, and it's just one of the issues with healthcare systems. They do naturally become more complicated. But I think the question is exactly the right one. How do we stop that happening going forward? Because it does add bureaucracy, and it adds delay, and it adds cost.
Okay, thank you very much. I have a couple of comments I want to read out, and then lots of questions about HTAs and a European HTA, as I mentioned. Compassionate use in clinical trials are exceptions to accessibility problems, bypassing the problem of delays to market and not necessarily a solution. These only target a few patients in certain countries. We need to reduce delays as well as asymmetries in access throughout the EU. There is a need for political and regulatory commitment, reduction of duplication and unnecessary red tape, and avoid a patchwork of policies. Another comment, not sure Norway can serve as an illustration for affordability challenges. Norway, an extremely wealthy country, can clearly afford any pharmaceutical. It has simply made a conscious choice to be very selective on what it wishes to cover for its population. Germany, with about half the GDP per capita of Norway, makes all medicines available quickly after EMA approval. So a suggestion there that, as I say, it's not, the Norway example doesn't necessarily help us. I'm going to just read out all these questions relating to HTAs, and we'll try and take them together and react to them. Someone saying, okay, if you have a joint European HTA framework, what would the role of local HTA bodies be? If countries wish to keep their power over what gets available to their population, be it through additional data requirements or through the requirement that the product be priced by other countries, what can the Commission do about it? And how could we aim to create a procedure for joint clinical HTA assessment in parallel to the MAA at EMA? This would accelerate the process and increase business predictability. So lots there. We may try to get some more, but clearly some questions. I think, Francis, this all comes back to the question I asked you at the beginning about how would this work if we did it? They're all related to how we really make it work. Can you pick up on any of those points?
There's a few ones. What EMA is doing, what marketing authorization is doing, is different from value assessment. Value is comparative, marketing authorization is in absolute terms and versus, this is cutting corners, but marketing authorization is an assessment in absolute terms and versus placebo or something like that. If you want an HTA and you want a value assessment, you want comparative analysis. And basically, EMA is not doing that. It's cutting corners, but well, that's one thing. What would be the place of the local ones? Well, there always will be some sort of a need of a translation of the central HTA in local terms, where you position actually the value assessment in what you want to do, and you have the economical part. And Tim already mentioned that one. It should be fairly fast doable to do a joint clinical assessment. The economical part, the budgetary part, everything which is, and that also is HTA. That is within the definition of UNETA definition of a health technology assessment. Also, the financial part is HTA. That is going to have to be done locally. How else would you do that? Because the organization, it might even be necessary to do that very locally. If you look at the region in Sweden or the regions in Spain, for instance, completely. One of the benefits that we have in Belgium that we are fairly small, and we only have and it's one system for the whole. Well, for the time being, it's one system for the whole country. Things might be different everywhere. You still will need the local HTA people doing the local work. Plus, UNETA is not going to do everything, and they're not going to. UNETA, I mean the European HTA system, never going to have the capacity to timely deliver assessment reports for all innovation that is coming. The volume is going to be too big.
Thank you. Gabriella, anyone else want to pick up on any of the points raised in those questions? Can we move on? There is one specific question to you, Kaiser. It looks as if we use your 5A's criteria, actual patient access is probably longer than the WAIT survey indicates. Have you compared countries in a similar way to the WAIT survey?
Yes, I think that was a question from Boris. No, the answer is no. That would be quite a big survey, and we are obviously looking at ways to get such data, but it's quite a big research project to organize that. But yeah, that would be interesting.
And a question here from someone: is there a willingness from European regulators to take different approaches versus the more conservative decision-making based on evidence, so providing the highest level of evidence? I think it's more of a sort of comment to, we don't have a European regulator on the panel, so can't get a reaction, but that question then of would it be very different? Would the approach be different? Is there? But let me come, if I might, to the question of dialogue. Because it was Dolores, when I asked her what was most important, and I asked her about whether we need a high-level forum, she talked very much about, yes, I'm telling everybody, that's what we need in this area, because stakeholders all need to work together on these issues. And we have a question here: how can we organize early dialogue across EU countries, allowing early mitigation of uncertainties, clinical and economic, ultimately leading to better and faster decision-making? Where do we have companies a platform? Where do companies have a platform for cross-country dialogue? So is this something, Gabriella, that you talk about between companies on these issues? And in terms of such a high-level forum, how important do you think that is, and where do you think its focus should be? Same question to you all.
Yeah, I think it would be really good to have a platform where we could exchange and where we can also connect the different levels of decisions. Because when we look into the access delays and all the factors, it's very complex, it's very we need to look at it holistically. There are some decisions made at the European level. There are decisions made in the country levels. There are very important stakeholders which we need to listen to, which we need to understand, which are coming from patients, which are of course coming from the pharmaceutical industry. And I think only together we can find solutions, or let's say improvements, to make a step towards giving better and broader access to patients in the markets where we see this kind of issues.
And for you, Francis, how important do you think it would be to have such a forum, and what for you should its focus be? This is separate from our conversation about the HTA framework, which is more specific. Here we're talking about a high-level forum to broadly discuss these questions of access to innovation. What do you see a role? Do you think it's important?
Yeah, I do see a role. We need a long-term agenda for Europe. and which has to be a political agenda too, because if you really want to talk to the people who, if you define access as really real access, so including affordability and including the reimbursement or some sort of a financial contribution of the state to the, then how on earth are you going to set such a forum? We do have those forums. We do have those sorts of discussions within the Benelux. Why do we have that in the Benelux? Because in the Benelux, we were able to actually identify all the stakeholders. Did anybody ever try to do a mapping of who is responsible for the ultimate, for the whole of Europe? Who is responsible for the ultimate decision to give access to a new therapy for an individual patient? In Belgium, it's not difficult. It's Risivinami, it's our national institute. But look at Italy or Sweden or France. You have to talk to hospitals, to hospital doctors, to hospital organizations, patient organizations. You have to talk to, in Germany, talk to the federal or to the federal and then to the regions and to the Krankenkassen and to individual, to Länder. In Sweden, you have to talk to what, 7 regions, 13 regions? I don't know. I do understand the need of such a platform, but this is not going to be simple to actually get everybody around the table. So probably you need something higher level and really high level, which means high political level.
And do you, and somebody was saying, okay, we've been talking about a European HTA framework. Is it actually going to happen? I think your answer there would be, first you need high level.
HTA one is good. That's science. That's something else. That will
happen. You think that will happen at the European level?
Yeah, there should be no doubt on science.
Yeah, but this is to discuss these broader issues, as you say, that we're talking about.
And on the clinical validation work should be the same.
Yeah. So
if there's a different perception of value between different countries and different HTA experts, then you have a problem with the product, not with your. Because I was wondering if the HTA, we have been talking a lot of HTA, is the quality of the HTA that bad in Europe? Is it really that bad? It's slow in some cases, but is it?
So speed, speed for you is the key issue here. Tim, such a high-level forum, were it to be created, what do you think it should focus on, and how do we make it work? And Kaiser, to you, you talked a lot about the voice of the patients in this. Do you see such a high-level forum as a way of maybe making your voice louder and really more central to this debate than maybe it has been? Question to you both, and then I'll see if we can squeeze in a couple more from the audience, and then we'll need to wrap up. But Tim, and just more broadly on this as well, for you, and when I asked Dolores what she wanted from the pharmaceutical strategy, that was really the thing she highlighted most. She highlighted the high-level forum and more powers for the European Medicines Agency as key elements. For you, is this the most important thing a high-level forum, the pharmaceutical strategy do? What else would you like to see in that strategy to address this issue?
Okay, big questions, Jackie.
Big question.
So in terms of the forum, I think it is important that it has the range of stakeholders I think Frank was starting to articulate. So there's a big question, I think, in the Q&As in the chat about what we can solve at the European Commission level, what has to be solved at the national member state level, what gets solved below that at the regional and the hospital level. So we need different stakeholders from the healthcare infrastructure side, the payer side, the industry side, the patient side, and the physician group side. So I think because this is multifactorial, because it's at a number of different levels, I think you need different stakeholders, and to recognize that the solution can only be done if the Commission can't solve all of this. Quite a lot of this is at the member state level. And then I think it's quite useful for us to categorize types of solutions. I think some of these things like compassionate use, early access are useful, but they're not useful in all countries. Germany doesn't need them because it's got instant access. So we need to start seeing that different solutions work in different countries, and different countries have different problems. Norway does have a different problem to some of the CE countries. There's about political prioritization in there as well as about affordability. So I think the forum is important. In terms of the pharma strategy, I would echo what Dolores said. I suppose my request would be, given my interest, more of a focus on the innovative medicine side in Europe. I think it is very important, security of supply, especially given coming out of COVID, etc. But it's really important that the innovative medicines get to patients in Europe, and we have a healthy industry in Europe. So I would be pushing the pharma strategy in that direction.
And do you have a specific request from that strategy for something to address that?
Well, the strategy sets out the discussion we had this morning. And it sets out that there's an issue of access across Europe, and starts to, hopefully we've extended it a little bit, starts to go in those root causes direction. What they haven't set out is how the dialogue picks up from here. So I think if you ask me what my number one would be, it is the structure for the discussion is the missing part in the pharma strategy.
And so for you, Kaiser, this idea of a high-level forum, how important do you think it is, and what would your key ingredient in the new pharma strategy be in order to address all these issues we've been discussing today? Accepting, go back to this where we started, it's complex, it's multifaceted, there is no silver bullet, but one thing you want to see in the pharma strategy to really address this issue.
Yeah. Yeah, I agree with the high-level strategic dialogue, in the sense that EPF has actually called for a high-level strategic dialogue in line with the European Parliament's proposals. And of course, we know that the Health Coalition has made a similar call. And indeed, it could not be resolving all questions, and as Francis said, it had to be at the high political level and look at the political questions and conceptual questions. For example, the question of what is a fair price, what transparency elements, discussion of value, added value, unmet needs, and all of these need a patient perspective. I remember years ago the activities flowing from the Pharmaceutical Forum, as well as then the Tajani initiative, which did result in important work done, especially on orphan drugs, biosimilars, and a collaboration with WHO that resulted in an update of a report on priority medicines. It was important then to have committed member states to take leading roles, as Belgium did at the time of their presidency. And so I think it needs political will and leadership, but also really critical to ensure broad civil society representation, and especially patient organizations. So that would certainly be something I'd like to see in the pharma strategy. Then I think if you want one thing, I'm going to sidestep a little bit, because there is also the issue of the quality of innovation and how much value it brings to patients. And one thing I really want to see, one major element that is still a bit undeveloped, is the embedding of patient involvement across the entire medicine's life cycle, from priorities for research, what matters to patients, to clinical trials design, make sure that the endpoints and outcomes are valuable for patients, which would then logically lead to easier regulatory assessment and HTA and pricing and reimbursement decisions at the end of the line, and patients need to be involved throughout. I think this is still something of a blind spot to some decision makers.
Thank you very much. Francis, your key priority for the pharma strategy, and I think you also wanted to react to something Kaiser said.
No, it's the key priority for the pharma.
Yeah.
I think we even have to restart a discussion on solidarity between the different countries. And that is going to be, look at what happened with COVID, when countries needed to probably start shutting their, closing their borders. Look at the safety of Europe. You look at the refugees. There's I think we have to restart the whole discussion on where we want to go with solidarity within Europe before we set any step. We can really realize something. So I hope
that would be for you the central issue, and one we can come back to. Gabriella, for you, key priority for the pharma strategy, what do you want to see in there? Is it the high-level forum? Are there other things that we really need to include within that strategy if we're going to answer this very complex problem?
Yeah, so I think we need a high-level forum, that's very clear, but we need also to have a joint vision on healthcare, but also on innovation in Europe, and also kind of healthy industry which creates innovation within Europe. So I think we need to start with this vision. What do we want to do, and what do we want to have as in Europe? And then we also, I think, need to be clear that we need commitment from member states. So this whole discussion cannot just happen on a EU Commission level without having a clear responsibility and commitment from member states across all the different stakeholders. And I really like to say that we need to sit together at the same table with all the different elements which can bring this kind of vision to life.
And on that uplifting note, the audience can't thank you, so I'm going to do it on all of their behalf. Thank you very much to all of you for a fascinating discussion. Lots more to discuss. We could have gone on for several hours, but I really appreciate it. Thank you, Tim, for your presentation in absentia. Thank you to Dolores for being with us earlier. And thank you to all of you for joining us for this session of massive attendance at this session, which shows just how important this issue is. Thank you for your many, many questions. We managed to address or at least touch on many of them. There were a few we didn't get to. Apologies for that. But keep those questions, keep those comments coming. I'm sure maybe we can respond to some of them after the event. So thank you again to our speakers. Thank you for listening and watching. May I wish you an enjoyable rest of the day and stay safe. Goodbye.
Thank you very much. Goodbye.
Goodbye.